health. We're going to see a couple of different definitions for global health. We're going to discuss some ethics of short-term global health experiences. We're going to understand the pediatrician's role in global health, and then understand the importance of global health education in pediatric residency programs. So this is one of the reasons that I'm passionate about global health. So you can see here, this is actually my very first global health experiences, and it's in Belize in March of 2009, so about 10 years ago, and we are all wearing matching t-shirts. How do you know that someone is going on a global health experience? Well, you'll see them in the Atlanta airport, a huge group of people sitting, waiting for some international flight to wherever, all wearing matching t-shirts. And so I hope that throughout my presentation today, you'll see why global health is more than just a t-shirt. So we're going to start with a case. So these cases are available online. Johns Hopkins actually has an online global health ethics training session, and so this is one of the cases there. And I wanted to go through with you guys so that you could see some of the things you might encounter in global health. And this is kind of a part for audience participation, so I hope that you will play along. So Sam is a medical public health trainee who is spending 10 days at a clinic working on a clean water project in the meningitis belt of sub-Saharan Africa. One day, a local community member with whom he's worked with on the water project brings her 2-year-old son to the clinic. The child has a high fever, is irritable, and resists any neck movement. Sam and his advisor suspect meningitis, the third case in 2 days. Sam's team brought with them a donated antibiotic, ciprofloxacin. While not the recommended treatment for meningitis, it has activity against Neisseria, the bacterium which could be causing the child's problem. Oral administration is not recommended for meningitis, but it could have some activity, and this is the only antibiotic Sam has. Sam also knows the receiving hospital can't perform blood or spinal fluid cultures, so starting treatment will not interfere with the diagnosis. So in this case, Sam is considering giving this toddler a dose of antibiotic to tide him over for this life-threatening infection until he can get to the hospital that's 3 hours away. So do you think that Sam should give a dose of this medicine? Yes, it might help, even if it's not standard treatment. Yes, he knows this woman's family and he owes it to them. No, because the treatment is non-standard, he shouldn't give it. Or it depends. Before deciding, he should talk to his local colleagues, take stock of the available supplies, and consider what future needs might exist for the Cipro. What do you guys think? D. So it's difficult to give a single answer to this kind of situation because in some instances, giving a non-standard antibiotic could be reasonable, but in others it might not. So he should really talk with his local colleagues and see if this is the best idea for this patient. So continuing on with the case, after sending the mother and son to the nearest hospital, he asks his advisor about the available antibiotics. The advisor tells Sam that their team is limited to what is contained in their travel packs that are donated to them. So what travel packs are, they're packaged collections of medications, supplies that are basically designed for medical outreach teams, and they're really cheap. They intend to kind of cover most, but not all, of the commonly encountered clinical conditions that teams might encounter in the developing country. And they kind of collect supplies through donations of pharmaceutical and medical supply companies. They pack them, ship them, and they can kind of help program teams efficiently obtain needed items, make sure that things aren't expired in those teams, and reduce the environmental impact through the standardized packaging. There are kind of several different kinds of travel packs that you can get, so it depends on where you are and if you get a travel pack, what will be contained. So in Sam's case, his team has travel packs that contain only Cipro. It has, of course, as you guys probably know, a lot of different uses. Treats UTIs, infectious diarrhea, some bone and joint infections, but it can't cover all infections as seen in the community, for example, meningitis. So Sam is troubled. Which of the following best expresses an ethical challenge with the donated items, in this case, the drug ciprofloxacin? So A, the local community had little say in what was contained in the travel pack and should be involved in choosing what's donated. B, the content of the travel pack did not meet the needs of the local community. C, the program should ensure that they never run out of needed drugs or supplies. This way, SAM won't have to worry about whether they have enough drugs for future patients. Or D, both A and B. What do you guys think? So it's actually A and B. So prospective donations really should respect the priorities of the local communities in terms of what's needed and what's appropriate for them. So really, travel packs and teams should look at local community needs, and we'll kind of get into that a little bit later. And just finishing up the case, Sam has learned 3 important lessons so far about the appropriate benefits. 1, whether a perceived benefit will be an actual benefit for the patient. It might be difficult to discern that. So we don't know with this kiddo. Is the Cipro going to help this kid or hurt this kid? Number 2, benefits should be responsive to local circumstances. And 3, in some cases, knowing how best to distribute benefits can be challenging, just like we have seen. So Sam realizes that his knowledge is growing, particularly when a friend calls to tell him he'd like to donate an old reverse osmosis machine to aid with sanitation in the area that Sam is in. So he asks his friend an insightful question, or a few insightful questions. All of them are appropriate except for one. So which question is not appropriate for Sam to ask this friend? A, have we asked the local community about this? B, is the technology appropriate? Electrical power is inconsistent here. C, does the machine meet donor safety standards? He's worried about setting a double standard. D, is it free? Or E, how can we ensure its sustainability? Do the machines require frequent membrane changes? What do you guys think? Yeah, is it free? So that's an inappropriate question to ask. Although cost may be important, the main issue is not whether or not it's free. Local communities might want to pay something for something like this, so you can't just say, is it free? One way to start thinking about whether benefits are appropriate is to ask questions like, who decided if this was needed? Was it the community who decided, or was it someone not involved in the community? Where is the location going to be for something like this? Was the community involved in that? And then is it sustainable? So that's a huge important question, because if the local community can't sustain something that you're giving them, then it's not worth giving them something like this if they can't sustain the whatever that they're receiving. All right, so that sort of hopefully got your mind thinking about the ethics of global health. We're going to have at least one other case that we're going to touch on throughout this talk. So first, we're going to start with the definition of global health. There are 3 good definitions that I found, all from different global health entities. So the first definition is AAP's definition of global health. It's a discipline that prioritizes equity in healthcare and stresses the commonality of health issues that require collective interdisciplinary action both within and across national borders. Copeland and his team defined it. Cookbush defined it as those health issues that transcend national boundaries and governments and call for actions on the global forces that determine the health of people. So why increasingly desiring global health experience in their training, both in medical school and residency? As of 2008, almost half of MD granting U.S. medical schools had established institutes, centers, or offices of global health. And health science students who have participated in global health experiences are more likely to care for the poor and ethnic minorities, are more likely to change focus from a subspecialty training to a primary care training. They're more likely to report improved diagnostic skills because you may not have all of the resources that you have in the United States. They express increased interest in volunteerism, humanitarianism, and public health, increased awareness of social determinants of health, which we all know is huge even in this area of the world, and then have greater understanding of resource utilization. And global health is also important to not only the trainees, but also to sending institutions. They may strengthen their position to recruit trainees who are interested in global health, and we'll kind of get into that a little bit later in the talk. And global health is also important because it's interdisciplinary and multidisciplinary. So a lot of people have to come together to make global health successful. So for me, this is why global health is important. So this is Haiti, just 2 months ago. Most of you know that Dr. Williams and Dr. Lexi Selzer and I went to Haiti for about a month. And we encountered a lot of the ethical dilemmas that we're going to talk about throughout this talk. And I'm just going to kind of give you one to just be thinking about as we go through this talk. So our very first patient on our very first day in the hospital, we did not have interpreters at this point. We were just getting there, getting introduced to everyone, starting to meet all of the residents and some of the attendings, and we were trying to get our interpreters together to be able to help us the next day. So the very first day, we're just walking around the wards, and we see a baby who is resuscitating this baby. So at this point, it was Lexi and I, Dr. Williams, and we had a Haitian resident who was with us. We all took turns coding her. And we coded her for probably 20 minutes before we got her heart rate back and she was breathing spontaneously. But we had the dilemma, we don't have a vent to put her on. So what do? So we would put her on CPAP, kind of let her ride. She would do well for a few minutes and then start to desat. And then we would have to bag her again, put her back on CPAP, wait a while. And so at that point, we had no interpreters. The family wasn't around. It was just us and one Haitian resident, and we asked her, what should we do? And she gave us kind of a question in return. Well, how long do you want to do this? Was her response to us. She said, we have a tube. We can get a vent from one of these other patients if you think this patient will do better than the patient who's currently on the vent. So this is real life that we were in. So just be thinking about this. What would you do in this scenario? And we are going to come back to this at the end of the talk to see if you guys have any answers on what maybe you would do. So let's get into the ethics of short-term global health experiences. So there are 4 main groups of people that the short-term global health experiences can affect. And we're going to talk about all 4 of them. The next few slides is a little bit wordy, and that's because it goes over a set of guidelines that will talk about how to do ethical short-term global health. So one of the groups is the patients, the local community, who is going to benefit from global health. So there are benefits and burdens for patients' well-being. So on the one hand, a benefit is that students or trainees are there and they may spend time with those patients, listen to those patients, be able to talk with those patients, and that may be a huge benefit to those patients, but they may lack the training to be able to know what to do with the information that they get. Trainees from resource-rich environments may have inflated ideas of what they can do in these settings. So they may be completely unfamiliar with the diseases in the area. They may not be the best ones to treat severe acute malnutrition or dengue shock. And when they get into that situation, what are they going to do? Local staff at local community members may see people coming in as kind of a chance to take an opportunity for a break and may not be there and may take a break and not be there for the community or for the patients that really need them. So those are just some of the things that you need to think about with the local community there. Trainees may not yet be prepared to be there. So if they haven't had adequate pre-departure training to kind of understand what they're about to see, understand some of the diseases that they might see, they may not be prepared at all. They may have stress and guilt over what actions that they took. So like the example that I gave from when Lexi and I were in Haiti, how do we deal with our decision that we ended up making? And we'll talk about kind of what we decided to do in that situation. And they may also place their own health at risk. So they can have bloodborne infections with no post-exposure prophylaxis. So when Lexi and I went to Haiti, we had no post-exposure HIV prophylaxis that wasn't outdated from 2014. So you have to think about all of those things before you go. Two other groups are the local staff and the host institutions. So it may pose a threat to meeting obligations to provide safe and effective health care within the constraints of their environment. The local staff can spend a lot of time orienting people who are coming there, and it may be hard to secure translation services. So just like our example, that first day we had no translators yet, and it takes time to get that secured while you're there. There can also be lack of oversight, and that can lead to global health experiences being kind of further reduced in time spent at the host institution because people are sightseeing, which can be both good and bad for the host institution. It's good for the tourism economy, but maybe bad for the institution that you're working for in that you aren't there. You said you were going to be there, and instead you're at the beach. And it may kind of cause people at the host institution to start to doubt your seriousness of your commitment to being there. Sending institutions really have to ensure that trainees are safe and that they learn from experiences that they get in global health. But they also benefit from global health experiences. So they get more recruitment from having a global health experience that residents or medical students can go on. Sending institutions also have a moral obligation to ensure that the patients and the host institutions are not left worse off than before the trainee went there and before the collaboration happened. And they have a moral obligation to help improve the care and service delivery of the place that they're going. However, they may have limited resources for assistance, and so they should really think about justice and how to best use resources that they do have to sending institutions. So with all of these kind of ethical considerations in mind, all of those four groups that could be affected by training in a global health experience, a group came up with what's called the WAIT guidelines, the Working Group on Ethical Global Health Training Experiences. And the next few slides, we're kind of going to go over all of the WAIT guidelines. It's going to be a little bit wordy, but I think it's important to show you guys kind of all of the things that you should consider when thinking about traveling abroad. So they're structured basically into the four groups that we just talked about: host institutions, receiving institutions, trainees, the patients in the community, and then the sponsors of the global health experience. And they're basically developed in response to the global health activities of educational institutions, so residency programs, universities, but they're applicable to all kinds of short-term global health experiences through churches or medical missions. And hopefully after seeing these, you will, if you do decide to go on a short-term medical trip, that you will use these guidelines to help. The hopes for the guidelines are to reassess and improve existing global health training experiences, and also to be used in the design of new training experiences, and, as bad as it sounds, to promote discontinuation of programs that can't meet these principles of ethical global health. So let's get into the WAIT guidelines. So sending and host institutions, they should develop well-structured programs so that the host and the sender and other stakeholders have mutual, equitable benefits. So discussing expectations and responsibilities, considering the local needs and priorities, recognizing the true cost to all institutions. So it doesn't just include getting down there, it includes lodging, transportation while you're there, having health care while you're there if anything happens, having administration help, and then of course touring. And it should also aspire to maintain long-term relationships so that the short-term experience may be kind of nestled within a more collaborative long-term relationship. And they should also promote transparency regarding the motivations for establishing and maintaining the programs. Sending and host institutions should clarify the goals and expectations and responsibilities through explicit agreements and periodic review by senders and hosts, trainees, mentors, sponsors, recipients. So everyone should kind of be on the same page. They should develop, implement, and regularly update formal training for trainees and mentors about professionalism, standards of practice, cultural competence, language capability, conflicts, personal safety, and then implications of the differential access to resources. Sending and host institutions should also encourage non-threatening communication to resolve ethical conflicts as they arise in real time, and kind of have a mechanism to involve both the host and sending institutions when issues aren't resolved. They should clarify trainees' level of training and experience for the host institution so that appropriate activities are assigned to the trainee, so we don't go down there and start performing surgery that we aren't able to do at home. We should do similar things that we do at home and there. Sending and host institutions should select people who are adaptable and motivated, sensitive to local priorities, willing to listen and learn, whose abilities and experience match the expectations of the position, and who will be good representatives of their home institution. They should promote the safety of trainees, so vaccinations, personal behaviors, medications, mosquito nets, physical barriers, security awareness, road safety is a huge one, sexual harassment, psychological support, and then insurance. So all of these things kind of have to be done before you're able to go. Sending and host institutions should monitor the costs and benefits, so to both the host institution, the trainees, the patients, the communities, the sponsoring institutions, to ensure that everyone has equity. They also should establish effective supervision and mentorship. So just like we had talked about before, making sure that we don't go down there and do things that aren't going to be supervised, that we would not be doing here. And then they should also establish methods to solicit feedback from the trainees, both during and on completion of their program. So what should trainees do? So these are the things that residents or medical students should do before going on a short-term global health experience. You should recognize that the primary purpose of the experience is learning and appropriately supervised service. And then the duration of the training experience should be tailored so that it kind of minimizes the burden to the host institution. They should communicate with their local mentor through official channels, their local mentor on the ground there in their country that they're traveling to, regarding what goals they should have, what expectations for the experience, and they should maintain communication with their mentors throughout the whole time that they're there. They should learn the appropriate language skills. They should learn kind of the sociocultural of the area, political, historical aspects of the host country. They should seek to acquire knowledge, learn new skills while they're there with the appropriate training and appropriate supervision, but be respectful of their kind of current capacity and current level of training so as not to exceed that. They should participate in the process of communicating to patients in the community about their level of training so that, like we said before, appropriate activities are assigned and that patient care and community is their well-being is not compromised. They should recognize and respect different diagnostic and treatment paradigms that they may see there that may not be the same that we do here. They should demonstrate cultural competency, engage in appropriate discussions about different perspectives and approaches, take measures to ensure personal safety and health, meet the licensing standards and the visas and the passports, follow international guidelines regarding donation of medicines and technology. They should plan their research accordingly, start doing that well before that they go. The rest of them are kind of about research and publishing different papers while they're there, kind of willing to share feedback on the training experiences, and then when seeking global health training outside of a well-structured program, to apply these ethical principles to that training experience. And then sponsors. This is very similar to the sending and host institutions. Promote the implementation of these guidelines. Make sure that people are following these guidelines. Consider the local needs and priorities and sustainability of programs that you're giving to the community. ensuring that the true costs are recognized, execute explicit agreements with the recipients, reviewing them periodically, helping to clarify goals and expectations and responsibilities, selecting trainees who are adaptable, the same set of trainees as before, promoting safety, encouraging supervision, comply with licensing standards, and then collect data on the impact of the program. So that was very wordy, but thanks for bearing with me through it all. I just wanted you guys to see all of those because I think it's important to know those in going forward of how to do ethical global health. So this is why all of us should be interested in global health. Why is it important to pediatricians? Well, 90% of the world's children, 90%, live in low and middle income countries. In those low and middle income countries, barriers to health contribute to significant child mortality and morbidity. So there's poor control of infectious diseases. There's insufficient chronic disease prevention. There's malnutrition that can contribute to worsening of any disease. There's healthcare worker shortages. There's armed conflict a lot of times. There are injuries, and there are environmental health issues. So pediatricians, according to the AAP, are dedicated to the health of all children. So we should work domestically and collaboratively across borders to improve the health of children throughout the entire world, not just locally. And regardless of nationality, culture, language, religion, or socioeconomic status, we should be caring for all of the world's children. Pediatricians now, even in the U.S., care for immigrants and refugees and non-English speakers. Even in our little clinic in Johnson City, Tennessee, we see this a lot, and international adoptees. 87.7 million U.S. citizens traveled abroad in 2017, so that meant that there was a lot of exposure to communicable diseases and health conditions that are prevalent in foreign countries. So really, we should all be aware of what's going on globally so that we can take care of children. Other reasons that global health should be important to pediatricians: the number of childhood deaths in low and middle income countries has decreased over the last 20 years because of a lot of the programs that have been implemented, but there are still 5.4 million deaths among children less than 5 years old. 43% of children less than 5 in those low and middle income countries, which is 250 million children in the world, are at risk for not attaining their developmental potential due to poverty and poor nutrition. The AAP has called for global health training for all pediatricians, and pediatricians should be global health advocates. So we should be advocating global childhood vaccines, research, pharmaceuticals, supporting policies that aim to fulfill achievement of the Sustainable Development Goals. So because of all of this, because pediatricians are dedicated to the health of all children, the AAP actually came up with a policy statement regarding the pediatrician's role in global health. So these are the 10 kind of bullets of the policy statement that the AAP came up with. So CME providers and departments of pediatrics should make training in global health available to all pediatricians and trainees. Pediatricians should recognize the differences in access to and quality of healthcare for children throughout the world. Pediatricians should become knowledgeable of best practices prior to short-term trips or long-term positions. Pediatricians are encouraged to advocate for government policies that support global child health. Pediatricians should work with international partners to achieve shared goals. They should incorporate the use of telemedicine for enhancing knowledge. They should use skills learned at home to benefit children abroad, but also use skills that were learned abroad to improve medical and surgical care for children domestically. So that's what's called reciprocal innovation. So using what we learn abroad to come back and maybe help with diagnostic management and maybe using less resources here like we would do there. AAP chapters are encouraged to play a role in offering global health training and service opportunities in their regions. And pediatric organizations are encouraged to consider a global health perspective in their mission and activities. And then pediatric societies and organizations around the world should collaborate with the AAP to promote long-term partnerships that support global health training, advocacy, and leadership. So now we're going to get into global health and pediatric residency and why this is important for residents and medical students. So I found several papers actually that really discuss global health training in specific pediatric residency programs. Now, as of December 2018 was the most recent paper I found, more than 25% of pediatric residency programs in the U.S. offer formal global health tracks. 66% of pediatric residency programs identify that there is a faculty member that is responsible for global health programming, and 42.4% of programs reported having international partnerships in about 150 countries. By 2014, 58% of pediatric residency programs offered international experiences. So this table was in that paper, and it shows the characteristics of residency programs that have global health training. I just highlighted programs that are similar to ours, so Southeast, about 20% of programs in the Southeast have a global health training program. As far as small residency programs, less than 30 residents, 30% of those programs have a global health experience. And then specific global health track, about 25% have a formal global health track. So this is from the APPD Global Health Database from 2014. This is a map that basically shows where U.S. pediatric residency programs are affiliated in the world with global health partnerships. So you can see the darker areas have more programs, the white shaded areas have none, and then the kind of speckled ones have in between. I think it's interesting to point out that Haiti, which, let me see, Haiti right here, it's a country that's the size of Vermont. It has 22 partnerships with residency programs in the United States. If you add that to the Dominican Republic, which is on the same island, the island of Hispaniola, there are 32 partnerships there. And then sort of very similar in East Africa, there are 40 residency programs that have partnerships there. So this is another table, same sort of thing, looking at it in a different way, the characteristics of the residency programs and what kind of global health training that they do have. I again highlighted the small residency programs, so you can see kind of the breakdown of what kinds of experiences residents are having. There are, in small residency programs, about 45% of small residency programs have a global health faculty lead. 30% of those have an international field experience. Global health lectures, you can see, are about 30%. 18% have a scholarly project. There's pre-travel preparation in about 50% of small residency programs who have a global health experience. And then you can see the breakdown of clinical and educational and research experiences in global health. So global health in pediatric residency is important. There are some benefits and difficulties. So benefits, you really improve the understanding of diseases that you learn about in residency. And those are the diseases that are the largest proportion of childhood mortality in the world. You have a deeper appreciation of issues related to cultural humility, professionalism, public health, and then you can maintain and foster compassion, humanism, and altruism. Some difficulties with having a global health experience in residency: you're practicing in a resource-limited environment. There are a lot of safety risks inherent in going abroad. There's a financial strain both on the resident and on the host institution for being there. And then there's, of course, the supervision piece that we have touched on before. This is an interesting figure that I found. This is the trends in global health career plans from 2018 to 2016. So you can really see how much global health interest has increased over the past, this was an 8-year period, overall plan to incorporate global health into their career jumped from 42% to 82% of pediatricians. Going internationally jumped from 32 to 71%. So this is huge. This is definitely a growing area that all pediatricians need to be aware of, and I think all residency programs need to be aware of as well, because it is an important piece of recruitment and an important piece of medical students finding their right residency program. So this is a paper that discusses basically how pediatric departments can support global health and how it can actually be a revenue generator, which I thought was very interesting, especially for a smaller program like ours. This is important because over the last 20 years, we have seen that huge rise in global health. And it's important to kind of know that and moving forward with any pediatric department. This article kind of looked to provide some guidance for pediatric departments on how to incorporate global health into their department and how to make it sustainable and make it kind of generate some revenue. So the one that looks like a table kind of talks about what supporting global health allows pediatric departments to be able to do. So one of the legs is education and training. So trainee interest in global health continues to grow. About a third of medical students in the U.S. have participated in some sort of global health experiences, and about a fifth of pediatric residents who are graduating have had a global health experience. 22% of medical students indicate that the presence of a training program in global health is integral into selecting a residency program. I can't tell you how many times in the recruitment process we got questions of, what kind of international experience do you have at your residency program? And then, as you saw, the AAP has called for training in global health for all pediatricians. And then along with the education piece, the expected competencies in global health have expanded. So it's far beyond now knowing a little bit about malnutrition, knowing a little bit about how to treat malaria, but now it's a huge focus to be able to work across different cultures, to be able to use interpreters effectively, which we should all know that now being here, how to care for recent immigrants, how to care for returning travelers, and how to provide value-based care with limited resources. The department who is interested in supporting global health should be able to respond to local and global needs. So we saw how many pediatric deaths, greater than 90% of pediatric deaths in the world occur in those low and middle income countries. So we have to improve the health of all children, and that requires an understanding of the issues that affect those children, disease management, solutions for children from these settings, on how to thrive. And then we also should provide care for underserved populations. That includes our populations here in East Tennessee, providing care for international adoptees, providing care for travelers, both pre-travel and returning travelers. Those are some of the kind of educational and training reasons that pediatric departments should support global health. There's also the clinical care and service piece. So committing to serving your community. This article discussed collaborating with other departments who have an interest in global health and collaborating with them to discuss global health issues, to maybe discuss having a travel clinic for families who are traveling, and kind of having a collaboration between different departments and different organizations that may help. For smaller departments who are interested in supporting global health, there are a lot of online curricula. So the case that we talked about earlier is one of the online resources, and I'll talk about another online resource that there is at the end that you can use to help develop a global health curricula. And then really, embedding global health into the department, having a faculty member or faculty members who are interested in global health, and recognizing that global health output and research is different than research and maybe QI here in the United States. And if you have faculty who are supported in the department, you have engaged faculty, and you have faculty who might want to stick around and see the development of the program further. So I just thought that was a really interesting paper that kind of hit some of the things that I think are really important in pediatric departments. So for more information, if you're interested in more about global health and the ethics of global health, I kind of have this list here. The WHO is, of course, a huge source of information about global disease and different organizations that you can get involved with. The weight guidelines, of course. The UN has a statement called the Convention of the Rights of the Child that talks about the basic rights of all children in the world. And then we have the Johns Hopkins cases, one of which that I went through with you guys earlier. There's a Global Pediatric Education Consortium that you can look at. AAP has its own section on international child health that you can be involved in and be a member in. There's this website called Sugar Prep, which Dr. Kumar actually took me to and showed me their website, and it's got a lot of global health cases, both ethical cases and medical cases, that you can go through and learn a lot about global health that way. And then there are a few books that I recommend anyone who is going into global health or doing a short-term or a long-term global health experience should read. The Spirit Catches You and You Fall Down is a book about a conflict between basically Western doctors and immigrant families. It's very eye-opening. It's a very good book. And then a lot of you have probably heard of Dr. Paul Farmer, who did a lot of work in Haiti. And there's a book called Mountains Beyond Mountains, and that is about Dr. Paul Farmer as well. So let's go back to our case in Haiti. We were walking through, found the apneic child. We bagged her, brought her back. We were going to see what we could do with her. What kinds of things would you guys do anything differently after going through this talk and discussing the ethics of kind of experiences? And I'll tell you guys what we ended up doing. Any thoughts?
What was the child in for?
So prematurity. She was a 30-week twin, and her twin was doing well, laying right beside her on a cart about this big.
What were the other patients who were on vents in the hospital?
One was there for pneumonia, and then I don't remember what the other one. There were only 2 vents there in the hospital, so one was there for pneumonia, and one was, I don't remember what the other one was there for. Yeah, they were older kids. So this was a premature. I think she was 2 days old, 30-week baby, whose sibling twin was right beside her and doing well. Nope. Nope. And mom was sick and in the hospital. She was sick with an infection after birth, and she was in the hospital, so she was not around. Dad was there sometimes with the babies.
Were any of the other 2 kids ready for a trial after that?
That was for us to decide. We were not taking care of them directly. It was our first day. We had no idea.
Was this baby on any antibiotics or anything?
She was. Mm-hmm.
She was getting the right antibiotic? Or?
She was getting antibiotics that they had there. So she was getting Ampingent, I believe. I don't remember if she was on caffeine or not.
They had just gotten there. She had 2 months.
Yeah. So a lot of these babies are born at home and just come in to the hospital when they can get to the hospital. And so that's what had happened. These babies were born at home and then brought to the hospital later when mom was getting sick. So they were all 3 in the hospital.
This is the classical example to use the CPAP that they use with the water,
Mm-hmm.
which is the low resource.
Yep.
That can have with these things on rather than putting on that.
Yeah, so that's exactly what we did. We bagged her, brought her back, put her on bubble CPAP. That was with just a water bottle and a little tube. And she would do well for like 5 minutes and then go apneic again. So basically our Haitian colleagues they were busy with other admissions. We could catch 5 seconds of a Haitian resident and ask what we should do. And after an hour and a half of intermittently bagging her and keeping her alive, we decided to put her on CPAP and let the dad hold her, which, you know, in the end was probably the best decision. She was really sick, and even with the ventilator, we don't know that she would have done well. So that's what we ended up doing. But that's kind of how we started out our global health experience, and we ended it in a very similar way with a very similar case. But it just highlights using your local people there in the country that you're in to talk with and see what they would do. And the Haitian resident agreed that that's what we should do. So that's kind of what we did in that moment. These are some pictures from Haiti. The top left picture is the picture of the entrance to the hospital. The bottom left picture is one of the courtyards within the hospital, and then the picture on the right is the church that is on the hospital grounds. So to finish up, maybe, I just wanted to show a clip of this is actually the hospital in Haiti that we were working in. I think it just highlights some of the things that you'll see in global health, and I think the pictures speak more than I could with words about the kinds of things that you may see in a global health training experience. And I think it encompasses a lot of the emotions that are involved. So I just wanted to show this. Hopefully it'll work. Maybe. Maybe not. I could do it outside the presentation. Just...
Is it a picture?
No, it's a video. Mm-hmm.
Should have a play. Do you know where the video is? On the internet?
Mm-hmm.
Okay, let's go. That way.
Sounds good. I don't want that. I don't know what that is.
I want to move it over one way or the other. Let's see.
Okay.
Try the other way.
There we go.
And then try to hit play. And it's muted.
Oh no. How do I unmute it?
It's like next to it.
Hopefully that won't be too loud. Okay.
Bigger if you want.
Haïti, c'est un pays, nous connaissons un pays fort, mais ça qui fait force Haïti, c'est nous.
You can imagine there are challenges living in a country with so limited resources.
Having chance to be acceptable at the hospital when your child is sick is not common in Haiti.
To work here as a doctor, you have to believe in what you can do. If you don't know it, you will fail.
We are 100% working for the people in need. I don't need to know who you are, but you are in situation, I go to help you.
We have been surrounded by dead children from the beginning. There are things to make you lose your mind. I tell you honestly. Proper care of the then leads to the proper care and the proper attitude of living.
If we think of how humanity has been able always to survive and go forward, not thanks to the leaders who have messed up the situations, but because of the hope of the poor people, many times do not count anything in the world. And then you see where the real history is, and it's many times not written on books.
The work St. David Hospital doing in Haiti, it's a work of justice and peace.
So I thought that was a good kind of way to end the talk so that you could see some of the things that you may see when you are traveling in another country and taking care of these sick children in another country. No, I need to try to get this back. Maybe. Sorry, guys. And it might keep talking, I don't know. Gosh. Oh no. It's fine. I don't know what's happening. Oh, there we go. So this is a quote that I wanted to end with. This is actually a quote from Father Rick, who was the priest that you saw in that video, who we worked with a lot in Haiti. This is the kind of thing that happens when you live in absolute poverty, when in the hierarchy of needs, all basic and essential, the needs must compete with each other, since you can only choose one at a time. So, maybe. Trying to just get to my resources slide. Here's my resources. Thanks, guys. Any questions? Sorry, I went a lot longer than I was expecting to. Yes.
Have you or Lexi coming back, like talk to anyone about your experiences?
Talk to, what do you mean? Talk to who?
Just, I mean, how have you, I mean, I don't know, I'm just asking.
We
information that you found.
We have talked with each other a lot about how maybe it still hasn't hit us yet, the things that we saw. We've met with Dr. Williams a couple of times since being back and kind of had a little debriefing one afternoon or evening about the things that we saw, and gave him updates about some of the patients that he left after he left while we were still there. I think it's easy to kind of push your feelings and thoughts to the side and just keep going with work, which is one coping mechanism. But I think we've leaned on each other a lot and talked with each other a lot, which has helped a lot. Yeah. Yes.
What's the average cost for somebody to go to do
a trip? So it depends on the kind of trip. So shorter experiences that I have participated in, that's how I got into global health, was shorter experiences as a college student, and they were like $1,200 for a week. When Lexi and I went for almost a month, it was probably like $1,800 for lodging and like the plane tickets. But that didn't include, some of that included food, but not all food. And
cost to you? What about the cost to the hosting institution and to the person going?
the sending institution and the host institution. So the cost for the host institutions are, I think, more in manpower maybe than dollars it's easier to look at. So we were relying on the residents there a lot, especially at the beginning. Like, how do we use this order set? How do we even treat severe acute malnutrition? What antibiotics do we even have? What labs are even available here that we can use? And so we took a lot of their time, which I think, of course, has some cost to the patients, spending their time with the other patients that are there. And then, the sending institution, so our institution, we weren't here, we weren't available for call, so it put a burden on everyone else who was here to do more call. So I don't know about dollar costs, but definitely manpower costs. I didn't see anything, I'm sure. So with the weight guidelines, it's talking about that a lot. So I'm sure it is being looked at. I didn't come across anything pediatric specific though. I don't know if you have anything to say, Dr. Kumar, about that.
I think it depends on the host facility and the nature of the
I hate
partnership.
to sound a pessimist, but does the host institution benefit more with that $6,000 rather than you being there?
Yes.
Yes.
Yeah, but the host institution understand, even if sometimes the visiting trainees and doctors don't understand, that it's a lot for their benefit as well. They're not going to donate their $1,800 to the hospital without the experience. So, but yeah, if you want to look at it, pure dollars and cents, because I used to be the volunteer coordinator at the hospital in Cambodia, so I kind of had the mindset of both the American doctor coming to poor country and the person who has to deal with the American, European, Australian doctors coming. It was very frequent that I would say, if they had just given us half the money that they spent on this trip, it would have been so much more useful than their own. They're a fish out of water in many senses.
Mm-hmm.
That case that you brought up, it was your first case. It might be very commonplace for the Haitians, and they might be wondering, why are they spending 2.5 hours on a dead baby, even though the baby wasn't technically dead when you were resuscitating. They might have, I don't know, but I could see them saying that, there's kids who are actually need to be treated. They're hanging out with that one baby that we would have spent 2 minutes or 5 minutes or maybe 20 minutes doing the CPR. And so when you're out of context, there's only so much help you can do. I found dentists and surgeons to be the most helpful.
You found what?
Dentists and surgeons, procedural-based volunteers who are just fixing things. For us, for medical, it's a little bit more nuanced. That's not to say volunteers didn't help. They definitely helped. But, you can easily make the argument the cost of their trip would be better served in cash.
I think that these
But I think it's okay to accept that the visiting doctors are getting a benefit. That's not a problem.
Do you think
I think that you have-
pediatrician because of your experience?
Definitely.
With 1 month of these things that you have learned as a pediatrician, your view of the certain things has changed and your approach to treating has changed? Because I think that's more important, what you
Definitely.
Because
Yeah, definitely. It forces you to work with limited resources. And even in an area that we're in now, families don't have a lot of extra money where we are now. So we can serve our families better by doing, less labs, less imaging, less tests if that's not going to change the outcome. So a lot of what we learned there was how to treat kids who were sick, without having a ton of supportive lab evidence, maybe only having a CBC, maybe that's all we had. And so that was definitely a huge lesson to bring back.
I think speaking to the financial aspect, though, I think it's important to realize that our collaborative with St. Damien last year raised almost $200,000 for the St. Damien Children's Hospital. So while yes, we spent $1,800 going down there, but if we didn't go down there, then we wouldn't be part of the collaborative and we wouldn't be raising that money. So I think ultimately, it gets us involved and it lets us come back and tell everyone what we're seeing down there, what the needs are and everything, and allowed us to raise that kind of money they're building a whole new ICU because of the money that we raised last year. So,
And that fundraiser last year was here in Johnson City that we did. And really, us being down there as well makes us, the people who have been there, more likely to donate in the future as well. Not just our time, but also our money, now that we have seen what it's like.
Graduating and become a physician, and that might be a cause that you would support that you otherwise wouldn't have if you hadn't had this experience that other people wouldn't.
Yeah.
I will say, what I've read about the St. Damien Collective, it's a very good partnership. So I said it depends on the nature of the partnership, the cost to the host institution. This is actually, they've done it properly. They have a lot of people who've been involved with global health for a long time, and I think went through the growing pains. It's an excellent partnership, and that was one of the big benefits, especially a medical student, like lower based trainees. It was good PR for the hospital in Cambodia. We would accept them. The first thing we would tell them is, you're not here to help us, you're here for your training, because that would help make everything smoother. When the med students were thinking they're going to save the world, it was when problems happened. But then they would go back and they would do, without us asking, they would do fundraisers. Some would do fundraisers, raise a few $1,000, $10,000, $20,000, you know. So there is as Lexi mentions, financial, like direct financial benefits further downstream.
I think that changing of perspective is a huge thing. I mean, it's changed your perspective on how you approach many things and how you view, lack of resources, how you might view a family here who doesn't have too many resources, and not feel like, oh my gosh, poor things, they don't have resources, but really actually help them understand what they have and what we can do for them. And then, like Dr. Kumar said, if you come back and then end up trying to help more with kind of that resource lack, or change your perspective on that, and then you spread your knowledge to all of us here today. So that's amazing, I think. That you do
Thank
that.
you, great talk.
Yeah.
Thank you. Any other questions?
I have one last question.
Yes.
So are you going to stay involved in global health in your future career at the pediatric hospitals?
Absolutely.